Hello everyone, we will be discussing mesenteric cyst topic here. We will discuss etiology, types, clinical features, diagnosis, management and complication that occurs in these patients. So mesenteric cyst is a benign cystic tumor that occur in the intestinal mesentery and it may or may not extend into the retroperitoneum. It has a well-defined lining of endothelial or the mesothelial tissue. Veniveni was the Italian anatomist who first described this disease by doing a autopsy in 8-year-old male in 1507. Rokitansky published first accurate description about the chylous cyst, that is the main type of the mesenteric cyst, in 1842. And Tilox did the first surgery over these cases in 1880 and also gave the Tilox triad. So incidence of this disease is 1 per 1 lakh to 250 lakh. Now coming on to the etiology, the exact etiology has yet to be ascertained, but there are probable reasons that we already find. So there may be the failure of the lymph node to communicate with the lymphatic or the venous system, and blockade of lymphatics as a result of trauma, infection or neoplasm can be there. There can be degeneration of the lymph nodes or the already existing lymphatic channel, or there can be failure of the fusion of the leaves of the mesentery with each other. So Gross theory combines all these and says that benign proliferation of ectopic lymphatics in the mesentery that lack the communication with the remainder of the lymphatic system can be the probable cause. So mesenteric cyst can be simple or they can be multiple mesenteric cysts. Uniloculated or multiloculated mesenteric cyst can be there, and these vary from few millimeter to few centimeter in diameter and as large as 20 to 25 centimeters at times. So a fluid inside the cyst comprises of, they can be chylous fluid, lymphatic fluid, or chylolymphatic fluid can be there. There can be serous or hemorrhagic changes can be there, as well as infective or mixed altered fluid we can see in these patients. So coming on to the types of mesenteric cyst, main type of mesenteric cyst that we come across is Chylolymphatic cyst, and this is having a thin wall and that is lined by flat endothelial tissue, and clear chylous fluid is present inside along with separate vascular spline. Another form of type of cyst can be enterogenic cyst, and these usually have thick wall and lined by the columnar epithelium or endothelium, and mucinous fluid has to be present inside as the content, and they share common blood supply with the bowel also. They occur anywhere from duodenum to rectum in whole of the intestine, but the most common region that encounters is ileal mesentery, small bowel mesentery, transverse mesocolon, gastrocolic ligament or retroperitoneum can be having mesenteric cyst. 60% of cases are seen in small bowel mesentery, while 24% are seen in the large bowel mesentery. 14.5% mesenteric cysts are having location in retroperitoneum, while others are 1.5% with indefinite location. Other term that we come across as mesenteric pseudocyst or pseudomesenteric cyst, and these are the cystic masses that are devoid of the epithelium, as we discussed in mesenteric cyst. Those were having endothelial or the mesothelial lining. So usually these are caused by trauma or infection. Other cysts that can be seen inside the peritoneal cavity can be the omental cyst, and these again can be chylolymphatic, lymphatic or chylous cysts. Our lymphatic system inside the this mesentery contain both chyle and lymph. So what exactly is the chyle composed of is of chylomicron, and that is the low ultra low density lipoprotein, it's also known as, and these particles are synthesized by our anterocytes, and they contain triglyceride, phospholipids, cholesterol, protein and apolipoprotein for the transportation to the liver from the intestine or the enterocytes. While lymph is clear to translucent and derived from the plasma of the bowel wall capillaries, and that passes the fluid to the blood vessels. So chyle is known as intestinal lymph, and it is having milky white color because of the chylomicron and the fat globules suspended inside the fluid. Just having a brief here about the this lymphatic drainage inside the abdomen. All of the lymphatics end up into the cisterna cali, that is being then carried to the thoracic duct, and that enters thorax from aortic hiatus at T12 and passes into the posterior mediastinum, followed by superior mediastinum coats, and in the neck it drains in between the internal jugular vein and subclavian vein junction over the left side. So coming on to the clinical feature, these cysts may occur at any age, but 1/3 of these patients present in less than 15-year age group. Clinical presentation can be asymptomatic presentation found incidentally in 40% of the cases. They can have non-specific symptoms, or patient can present as acute abdomen case in the emergency at times. So abdominal mass is palpable in 50 to 60% of the cases, while pain we come across 80% of the mesenteric cyst cases. Nausea, vomiting can be there in 45%. Constipation and diarrhea can also be the symptoms. So discussing here is the Tilox triad that was given by Paul Gilles Tilox, and it was a French surgeon. It's a fluctuating swelling that is more of palpated near the umbilicus, and this is freely mobile perpendicular to the line of mesenteric attachment. And on percussion we come across two notes. One is zone of resonance and another is dull note. Resonance is present where the bowel lobe is comes in front of the cyst. On the other side we may find the dull note because of the fluid inside the cyst. So diagnosis completely depends upon your history, detailed history, then clinical examination, and blood investigation can be added on into the patient, while radiological investigations may help us in confirming our diagnosis. So in radiology we do the X-ray abdomen, and that gives us a hollow fluid filled cavity, as we can see in this X-ray, that displaces the bowel gas because of the presence of the cyst. So other can be ultrasonography or CT scan that can be done for these patients, and here we can find the cyst, large cyst in the mesentery that is carrying fluid with a well defined wall that is covering whole of the cyst. Differential diagnosis are very important for these patients. There can be intestinal duplication cyst also. Meconium pseudocyst can be the differential diagnosis, while urachal cyst, ovarian cyst, paratubal cyst are also common in pediatric age group. Hydrometrocolpos, hematometrocolpos can be other differentials, while peritoneal hydatosis or choledochal cyst, pancreatic cyst or pseudocyst. Then diverticulitis, appendicitis, or rarely splenic and renal cyst can be the differentials for this cystic lesion. So management again depends upon the clinical presentation of the patient and how are the hemodynamics of the patient. Complete excision of the cyst or cyst enucleation is the treatment of the choice. Bowel resection may be necessary once we are dealing with the enterogenic cysts, and they may need a resection and anastomosis because of the removal of part of the bowel along with the cyst. Drainage of cyst is preserved for inoperable cases, and nearly it's obsolete. In most of the scenarios, complete excision or enucleation is feasible. Mackenzie was the first laparoscopic surgeon who did laparoscopic mesenteric cyst excision in 1993, and as discussed, robotic mesenteric cyst excision is equally safe and effective. So these are few clinical images of operated patients. We can see the unilocular as well as the multiloculated mesenteric cyst in these images. So complications that we come across in these patients are volvulus can be there. There can be mesenteric torsion, or there can be rupture and spillage of the content inside the cyst. Ball ischemia, necrosis, and perforation may also follow these cases, and intestinal obstruction or delayed adhesive obstruction or intestinal herniation of the bowel because of any mesenteric defect, iatrogenic, or anastomotic bowel leak or chylolymphatic can be the part of the complication in these patients. So mesenteric cysts are having excellent prognosis, and they rarely reoccur once completely enucleated, and malignant cyst transformation occurs in less than 3% of the cases. Thank you.